Good morning, everybody. I put together a little talk that I think is important in terms of understanding degenerative disease of the brain. Last week, we saw a number of patients with different types of degeneration of cortex. And I thought I would put it in together for you to make it easier to remember. And I want to emphasize that we're changing our concepts. When I started in medical school, it was called degenerative diseases. Usually we use that term when we don't know much about the cause. So we used to lump everything together in terms of dementias. The broad category here is dementing illness or dementia. But I want you to remember that it seems like virtually all of the dementias have some kind of abnormality in protein, either the production of the protein or the turning of the protein or the wrapping of the protein and so forth. So I'm going to call this essentially proteinopathy. And I think in the future, this term will be used more than just degenerative disease. And so my purpose this morning is to spend a few minutes to separate the various known diseases into their abnormalities in protein. And I'm going to make this interactive, and everybody's welcome to join in. So we'll call this proteinopathy as a new terminology moving forward from now on. It'll be called proteinopathies. Let's deal with Alzheimer's disease. What is the abnormality? What is the abnormality in Alzheimer's disease?
Amyloid beta, tau.
Right. So there are basically two proteins.
Dr. Bernad, we've lost the camera. The feed is off.
Okay.
Good morning, Dr. Stein. Good morning, Dr. Bernad.
Good morning.
Okay, now
Good morning, Dr. Naka.
Good morning, Bernard.
Right. We're just starting, and we're going to talk about dementing illness or dementia. We've had a number of patients last week who had different kinds of dementias. And so I thought about it, and I wrote a little piece here, put it together. Instead of calling these dementing illness or dementia, which is the old terminology, let's actually talk about what is abnormal. And in all these conditions that I'm going to mention, it's the abnormality in the protein, either making it, wrapping it, turning it, or excreting it. It's an abnormality in protein. So think about degenerative diseases. We start with Alzheimer's disease because it's very common. We see a lot of patients with it. And you told me that this is an abnormality in two proteins, right? What are the two proteins?
Tau and beta
Amyloid
amyloid.
beta.
Beta amyloid.
So it's beta amyloid is one type of protein, and tau protein. These are the two kind of abnormalities. So let's move on to the next one, which is Parkinson's disease.
Alpha-synuclein.
Right. Another term for Parkinson's disease is alpha-synucleinopathy. Okay, so it's another protein that is abnormal in Parkinson's disease. Now, one of the secrets as a clinician is that when I diagnose somebody with Parkinson's disease, and if over years of practicing, you can almost see a patient at a distance and make a diagnosis clinically of Parkinson's disease. When I treat them with Semantic or L-DOPA, carbidopa, combination, various combinations, if they don't get better, then they probably do not have the alpha-synucleinopathy. Okay, so that's kind of a little secret that you may want to think about. So I frequently use the medicines to test my hypothesis. And by the way, in all of these conditions, you can more or less make a diagnosis on a clinical basis at the bedside, taking a very good history, doing an examination, you can almost arrive at, not all the time, but most of the time, at some appropriate diagnosis. So Parkinson's disease. What about, is there some other condition? Lewy body
Lewy
disease.
body dementia.
So in Lewy body, we also see what? What protein do we see?
Alpha-synuclein.
Alpha-synuclein.
Very good.
And
And what else? What other condition?
supranuclear palsy. That's also
Frontotemporal.
Well, we're going to get to that. But multiple system atrophy, have you heard of that? We have a number of patients. They die relatively soon, and they become immobile. They look like Parkinson's disease initially. They don't get better with treatment. They don't get better with the treatment. There's no treatment for multiple system atrophy. It turns out that they also have this alpha-synucleinopathy. The patients appear rigid. They have problems in movements. They become weak. They usually end up on a respirator. And you can keep somebody alive for many months, years. But they are kind of stiff, and they're lying on their backs, and they most often die from what?
Pneumonia.
And pneumonia, exactly. I want to go on to the next degenerative condition, motor neuron disease. How many of you know motor neuron disease? Yeah. Unfortunately, every patient that I have with motor neuron disease usually
ALS?
dies. Now, ALS is the term that we use in America. Different countries use different terms. In England, it's more motor neuron disease, right? But it turns out that motor neuron disease is also a degenerative disease. And it also has protein problems. Who knows the protein abnormality in motor neuron disease that's been recently discovered? I'll try to explain.
DDP-43.
Yes, it's DP43. DP43 has been identified, and variants of DP43 have been identified associated with motor neuron disease. And another condition, and somebody mentioned that last week, is frontotemporal dementia as well, which is kind of related to motor neuron disease in terms of the pathology, in terms of the abnormal protein. Now, DP43 is really a research tool, and it's a type of protein that's hyperphosphorylated, and it has, anybody know what the chemical associated with it?
The RNA is.
It's ubiquitin.
Yeah,
Ubiquitinated. So when you measure it, it has another type of protein, and it's positive, but not all of the patients with motor neuron disease have this. It also may have tau protein as well. The alpha-synuclein is usually negative, and the condition, the frontotemporal dementia problem and motor neuron disease have this relationship, although clinically they look very different.
And C9orf as well.
Yes. In the frontotemporal condition, there's lobar degeneration. What was the old terminology for that? Pick's disease. We mentioned two other conditions that are tau positive, the protein tau positive. There are two other degenerative conditions or protein abnormalities. One is, we mentioned it last week, progressive supranuclear palsy, right? And what's the other one?
I know about chronic.
The other one is cortical-basal degeneration, fairly rare. So cortical-basal degeneration and supranuclear palsy, progressive supranuclear palsy.
Dr. Bernad,
Tau protein positive, yes.
I know about the tau proteins in chronic traumatic encephalopathy. Also, they've seen that beta amyloid and tau proteins.
Yes, it's interesting that There are other conditions that overlap, right? You can draw a Venn diagram. There's overlapping findings in many of these conditions, including traumatic encephalopathy. Yes, correct. Now, I want to just mention one more, which is a familial MAPT. How many of you are familiar with that? This is the familial type of dementia. It's a microtubular associated protein tau abnormality. So it's another one. It's very rare. It's definitely genetic. It runs in families. It's a microtubular associated protein, and it's frequently in families. It's fairly rare, called MAPT. Now, I want to identify the frontotemporal dementia because we had a number of patients. And you remember last week, we had a patient with difficulty communicating. We diagnosed her as dementia, and I want to get back to that for a minute. What kind of dementia did we think she had? Remember, she came with her husband, and she was sitting. She was in the office in the Potomac Center, and her husband was next to her. This was a frontotemporal dementia, but what other terms? Remember, she had difficulty communicating.
Started with aphasia.
Aphasia.
Aphasia, that's a big term, aphasia, but there was a special type of aphasia called semantic.
Yes, semantic type
Mhm.
of.
It's a semantic dementia is what we're talking about. And I wanted to emphasize this. There are various types of semantic. And I don't want to go too far into the weeds. I just wanted to kind of hit the highlights. But there's a type C, which is a neurotic superficial cortical type, involves superficial layers. And there are no neuronal cytoplasmic inclusions. These patients have verbal difficulties. They lost their ability to use certain words. Remember, we found that she couldn't name things. She was very pleasant. She was almost what we call a fluid type of aphasia. She had a lot of gibberish, words didn't make sense, and so forth. Some of these patients were very intelligent at one time, teachers, writers, and so forth. And she was a little bit pleasant, wasn't she pleasant?
Yep.
She seemed to know her husband, but they're unable to really communicate. So these are the semantic aphasia patients. And they also have a dementia. They have a progressive condition. The problems may be in the cytoplasm. There may be inclusions in the neuronal nucleus as well. And they're in different layers of the central nervous system. So there could be intranuclear inclusions or even glial cytoplasmic inclusions. There's a loss for words. There's a loss of naming. There's a loss of communication, difficulty in communicating. No weakness. Remember, she had no focal weakness or paralysis. And she has been about the same. I've been following her for about 6 years. I think she has a semantic dementia. They usually last 10 years. And they have progressive problems. Sometimes we call it primary progressive aphasia. That was the old terminology because they looked aphasic and it seemed to be progressive. And they go from some loss of words, loss of communication, loss of naming, until they can't speak anymore. And we've had a number of patients like that. It's very tragic. It's especially if you knew the person.
Dr. Bernad?
Yes.
I read a paper in NEJM. It was on language dominant dementia. So
Yes.
would that be similar or that's something different?
No, that would be similar in terms of semantic and an inability to communicate effectively. I don't want to go into parts of semantic dementia. There are subcategories, but I think the big picture is that they are unable to communicate. They have a dementia, but they look different from Alzheimer's disease, Parkinson's disease, progressive supranuclear palsy, and so forth. Yes.
Parietal atrophy will be seen with the language.
Sometimes you can see atrophy. MRI of the brain can show some atrophy, and also PET scanning. Remember, we ordered a PET scan on one of the patients. PET scanning still is very expensive. Many insurance companies don't want to do it. So you're looking for loss of tissue, atrophy, or alteration in glucose metabolism. But I wanted to kind of bring this to your attention to think about degenerative diseases in a different way. Think about it as a protein abnormality. And that's my own purpose this morning. Yes.
Would it be possible as well that there's a geographical classification, one, and then second, genetic classification, like based on the race, like Caucasians and then African Americans, Asians, that there's a different trend in what's causing or which protein is affected that's leading to the dementia?
Definitely. I think that ultimately, virtually all of our diseases have a genetic underpinning and maybe some environmental factors that come around at a later time. But as we're studying these conditions, there's definite genetic problems. The most common of the genetic problem is sometimes the protein production or protein folding. In some of the other conditions, it could be repeats, the abnormalities like the CAG repeats.
Mm-hmm.
One condition that we know, we have a patient, and I think he's coming in with spinocerebellar atrophy. Have you heard of that?
Yes.
Spinocerebellar atrophy type 3.
Machado Joseph.
Exactly, Machado Joseph. He's Portuguese, so he would know this condition very well. How many of you heard of this condition? You should really study it a little bit. Many doctors have spent their lifetime studying this condition. It is very common. It's very common in the Azores, the Portuguese Azore Islands. And we have 2 patients with this that I've been following with the cerebellar ataxia. And it's very interesting for me. First of all, what is ataxia? Who can define ataxia?
Coordination.
Inability to coordinate balance.
Okay, now remember you have ataxia. What about tremor? What is tremor?
Tremor is irregular rhythmic movement of the arms or the extremities.
Around the point, right? It's
yes.
Above or down. So tremor
voluntary.
Exactly. It could be an increase or decrease. So tremor is different from ataxia. How about dystonia? What is dystonia?
Involuntary muscle contraction.
The muscle stiffness, right? Stiffness.
Yes.
And interestingly enough, the Machado-Joseph disease has all 3 of those, but it's a very interesting condition that we should study. And there are variants. It's been one of the most deeply studied condition, especially in Boston and in the Northeast.
New England's Fall Rivers.
Many of the folks from the Azores, from the small islands in Portugal and Portuguese, they moved to the New England area. So some of the initial families moved there. And there were many cases described in Boston and Massachusetts and elsewhere. All right, so I didn't want to take up any more time. I just wanted to have a little introduction to this subject of proteinopathies. I'm through. Okay.
So Dr. Bernad,
Yeah.
Joseph's disease is spinocerebellar ataxia. Is that what it is?
That's correct. It's a type 3. There are varieties. It's a dominantly inherited disorder. So usually you have a mother or a father who had it. You have a 50% chance of acquiring it. The condition is variable. In other words, it can go on for many years. And you can be quite young when you are diagnosed, or actually older, age 70, for example, we'll still see somebody who may have that condition. In some ways, it's genetic. It's dependent on, let's say, your mom or dad. If they had a very mild condition, the child may actually be worse. And this is one of those CAG repeat abnormalities.
Anticipation, yeah.
It's called anticipation. Very good.
It's
I think
similar to
we have some good doctors here. Dr. Stein, you picked a great group.
This is a great family of doctors.
Is it
it's-
similar to the Huntington disease, doctor?
Well,
EAG repeats something.
Yes, we also have a similar, we have a number of patients with Huntington. And of course, they have dementia, and they also develop movements, the movement disorder
Korea.
in Korea.
Mhm.
All right. Okay, it's exactly 9:30. So I promised you, mine will be a short presentation. Somebody's presenting today? Somebody else? Yes.